Bismillahirrahmanirrahim. Quote of the day is Prophet ﷺ said, "He is not a believer whose stomach is filled while his neighbor is hungry." My name is Dr. Aamna Khalid, and I will be presenting the topic of nutritional problems and assessment of nutritional status under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health, Lahore. A learning outline for today's presentation are: we will go through the types of malnutrition, nutritional problems in public health, concept of food gap, web of causation, levels of prevention of different problems of malnutrition, methods used for the assessment of nutritional status, recent updates, and the MCQs. So malnutrition refers to the deficiencies, excess, or imbalance in a person's intake of energy and or nutrients. There are three broad groups of malnutrition. First one is undernutrition, which includes wasting, stunting, and underweight. We will go through the detail in next slides. Then second one is the micronutrient related malnutrition, which includes micronutrient deficiencies. There will be a lack of some specific vitamin or mineral. A micronutrient excess can also be there. And there are diet related non-communicable diseases, specifically related to the overweight and obesity. These include heart diseases, stroke, diabetes, and some cancers. Undernutrition is further categorized into the four categories: wasting, stunting, underweight, and deficiencies of the minerals or vitamins. And undernutrition makes children in particular much more vulnerable to disease and death. First of all, we will see wasting. A child whose weight for height z-score is at least uh, two standard deviations below the median in the WHO child growth standards. Uh, this is labeled as wasting. If it is between second and third standard deviation, it will be labeled as moderate wasting, and if it is less than the -3 standard deviations, then it will be labeled as severe wasting. This classification is according to the WHO. Wasting represents a recent failure to receive adequate nutrition and may be affected by the recent episodes of infections like diarrhea or other respiratory infections. It indicates current malnutrition resulting from failure to gain weight or actual weight loss. And wasting also shows marked seasonal patterns associated with changes in the food availability or disease prevalence to which it is very sensitive. Then stunting, a child whose height for age z-score is at least two standard deviations below the median in the WHO child growth standards. Stunting results from chronic or recurrent undernutrition. It's usually associated with poor socioeconomic conditions, poor maternal health and nutrition, frequent illness, inappropriate infant and child feeding and care in early life. Then the third category is underweight, a child whose weight for age z-score is at least two standard deviations below the median in the WHO child growth standards. A child who is underweight may be stunted, wasted, or both. So it actually represents both chronic or acute malnutrition or both of them. It is often used as a basic indicator of the status of a population's health, and the evidence suggests that mortality risk of children who are evenly mildly underweight is increased. Then comes the micronutrient related malnutrition, inadequacies in the intake of vitamins or minerals, often referred to as micronutrients. These are grouped together. So undernutrition of some minerals like calcium leads to rickets, iodine deficiency leads to goiter, iron deficiency leads to anemia, zinc deficiency leads to growth retardation. And then the undernutrition of some vitamins like vitamin B1 leads to beriberi, niacin deficiency causes pellagra, vitamin C deficiency causes scurvy, and vitamin D deficiency causes rickets. We will go through some scenarios. This is a history of scurvy that in 1747, Scottish naval surgeon James Lind conducted. what is considered the first randomized controlled trial. He treated a group of sailors with scurvy and found that those who ate citrus fruits such as oranges and lemons recovered, while the others did not. Uh, then we will go through the scenario of pellagra. We are actually done with a very detail of these minerals and vitamin deficiency and their disorders associated with them in the previous classes. So I'm just going through the quick revision of all of those things. So the Pelagria scenario, sorry, a 32-year-old woman from a rural low-income area presents with watery diarrhea, photosensitive hyperpigmented rash on the hands and neck, and irritability with recent memory issues. Her diet consists mainly of maize with very little milk, meat, milk, or pulses. On examination, the rash is bilateral and rough, worsening with sun exposure. No major comorbidities are reported. The clinician suspects a niacin deficiency that led to pellagra. So diarrhea, dermatitis, dementia, these are the major symptoms. Then comes Barry, a 28-year-old man from a low-income community presents with progressive leg weakness, tingling in his feet, and difficulty in walking. He reports a diet mainly consisting of polished white rice with very little protein intake. Examination shows peripheral neuropathy, muscle wasting, and reduced ankle reflexes. He also complains of occasional palpitations and shortness of breath. The clinician suspects thiamine, that is vitamin B1 deficiency, leading to beriberi. So the situation of mineral deficiency in Pakistan is that iron deficiency is 28.6%, and zinc deficiency is 18.6%, and the remaining are non-deficient. Then we come to overnutrition, a pathological state resulting from the consumption of excessive quantity of food over an extended period of time. The high incidence of obesity, atheroma, and diabetes is attributed to overnutrition. In adults, overweight is defined as a BMI of 25 or more, whereas obesity is a BMI of 30 or more. Among children and adolescents, the BMI thresholds for overweight and obesity vary by their age group. So the diet-related non-communicable diseases, these include cardiovascular diseases like heart attacks and strokes, and they are often linked with high blood pressure as well. Certain cancers, diabetes, unhealthy diets, and poor nutrition are among the top risk factors for these diseases globally. Then we have severe acute malnutrition when the weight for a height Z-score is 3 standard deviations below the median in WHO growth standards, and the middle upper arm circumference is less than 115 millimeter, and there is presence of nutritional edema. We label it as severe acute malnutrition. Protein energy malnutrition is the condition resulting from deficiency of proteins or along with calories, leading to insufficient nutrient intake to meet metabolic demands. These are divided into two categories, kwashiorkor and marasmus. Kwashiorkor is the maladaptive state where there is low plasma proteins leading to edema. There will be skin changes, hepatic dysfunctions, large liver will be there. This is hard to treat and high mortality rate is there. And then marasmus is the adaptive stage. There is very low weight for height Z-score. Both fat and muscle loss is there. Severe muscle wasting, and the child is stunted. Straightforward to treat and low mortality if it is treated promptly. Then another nutritional problem is the low birth weight. When the birth weight is less than 2,500 grams, like 2.5 kilograms, irrespective of the gestational age. Consequences of low birth weight are that there is increased risk of neonatal death, infections, growth retardation, and the long-term effects include poor cognitive development and increased risk of chronic diseases in the adulthood as well. The causes of low birth weight are the maternal factors, including malnutrition and anemia. Malnutrition and anemia are the most important risk factors for low birth weight. And the other factors are teenage pregnancy, short birth intervals, infections. Social economic factors include poverty, illiteracy, poor antenatal care. Fetal factors include multiple pregnancies and congenital anomalies. Another nutritional problem is fluorosis. That's a chronic condition caused by excessive intake of fluoride through drinking water, food, and industrial exposure. And the types of fluorosis include the dental fluorosis, skeletal fluorosis, and non-skeletal fluorosis. The more important is the dental fluorosis, in which there is chalky white spots or the appearance of the teeth initially, and then there is yellowish or brown discoloration in the later stages, pitting of enamel and an increased brittleness of teeth. You can see in the picture the normal teeth, and then in the mild stage there were white spots, and that turned into the yellow and brown colors. And then another nutritional problem is nutritional anemia. That is the most common nutritional problem worldwide. Iron deficiency anemia is the commonest form or the cause, and this affects pregnant women mainly, and the infants and preschool children and adolescent girls. You can see different symptoms of anemia in the picture below. There is pallor and the stomatitis and the strawberry tongue. Causes of nutritional anemia are dietary due to the inadequate intake of iron, poor bioavailability of it. Physiological causes include increased requirement like pregnancy and growth, blood loss like menstruation and hookworm infestation, infections like malaria and helminthic infestation. Another nutritional problem is iodine deficiency disorder, a spectrum of disorders resulting from the iodine deficiency affecting growth and development, the leading cause of preventable mental retardation, and it affects fetal brain development and endemic in hilly and sub-Himalayan regions. Then comes xerophthalmia, that is a group of ocular manifestations caused by vitamin A deficiency ranging from night blindness to corneal blindness, and it's a major cause of preventable blindness in children. It increases the severity of infections and child mortality. Then we have some dietary factors and associated cancers, like taking the high animal fat diet can cause breast cancer and the colon cancer. Low fiber diet can cause colon cancer. Smoked and salted foods can cause stomach cancer, and again the nitrosamines also cause stomach cancer. Aflatoxin contaminated foods can cause liver cancer. Refined carbohydrate-rich diet can cause colorectal cancer, and a low fruit and vegetable intake can lead to oral and esophageal cancer. Then diabetes mellitus is associated with the excessive consumption of refined carbohydrates, sugars, and high-calorie foods. Dietary fiber intake, and it can result into the obesity, insulin resistance, and type 2 diabetes mellitus. Now we come to the global burden of these nutritional problems. In 2022, approximately 390 million adults were underweight, 2.5 billion were overweight, while 890 million who were living with obesity. Among children and adolescents ages 5 to 19 years, 390 million were overweight, including 160 million who are living with obesity, another 190 million living with thinness. Uh, so again, from the data from 2022, an estimated 149 million children under the age of 5 years were suffering from stunting and 37 million overweight or obesity, and nearly half of deaths among children under 5 are linked to undernutrition, and most of them occur in low and middle income countries. This is the map showing share of children who have vitamin A deficiency. And you can see that Pakistan is in the lighter shade, like 10 to 20% share of children with vitamin A deficiency, but our neighboring countries like India, Afghanistan, etc., shows a darker um, shade, means the more children are vitamin A deficient. This is another map of children under 5 who have night blindness, and data is similar. The Pakistan is in the lighter shade from 0.2 to 0.5%. This is the share of the population with anemia in the high-risk groups. The data from 2019. 60% of the children from low-income countries are suffering from anemia, and 51% of the children in the low-middle income countries are suffering from anemia, and the percentage is getting better. In the upper middle income countries, it's 24% for the children, and for the high income countries, it's only 14%. And the similar percentages are seen for pregnant women and the women of reproductive ages, that they get better with the um, economy of the countries. And then this is the death rate from malnutrition data from 2021. Pakistan has the death rate of 1.3 per 1 lakh people. Then this is the map showing the global iodine status in the school age children. The countries in pink color shows that there is insufficiency of the iodine, and the green countries show the dark green countries show that there is adequate level of iodine status in the school age children, and Pakistan is one of them. And the gray countries, only one or two, they have excessive iodine intake in their children. Then burden of disease in Pakistan, 40.2%, uh, 40.2% rate of stunting is there, and 63.1% food insecurity, early initiation of breastfeeding in 45.8%, and exclusive breastfeeding in 48.4%. This is the conceptual framework by UNICEF for the determinants of maternal and child nutrition. That governance is the first step, and then in the next step we focus on the resources and the norms of the society, and then in the these are the enabling determinants, and then we have underlying determinants which include food and the practices of the feeding and intake, and then the services provided to the people. Then we have immediate determinants which are diets and care provided to children and women. And then we have the outcomes for children and women, which includes the improved survival, health, physical growth, cognitive development, and so on. Web of causation, there are numerous contributory factors in the web of causation of malnutrition, including poor environmental conditions, large family size, poor maternal health, failure of lactation, premature termination of breastfeeding, and adverse cultural practices related to the child rearing and weaning. Then there is a concept of food gap. This is a term used to describe a shortage between the food a population needs and the food that is available. And this concept has two main interpretations: the discrepancy between food supply and demand, and a gap in knowledge or evidence needed to create sustainable food systems. And then one thing is malnutrition and infection vicious cycle, that the inadequate dietary intake leads to weight loss, growth failure, low immunity, and mucosal damage that causes further infections, and the infections further causes appetite loss, nutrition loss, malabsorption, altered metabolism, which again causes the inadequate dietary intake, and the vicious cycle goes on. And now we come to the classification of malnutrition. First one is the initially we discussed the WHO classification in the definitions, and the second one is Bohm's classification that focuses on the weight for age. That if the weight for age is 90 to 110%, then it's normal. If 75 to 89%, that is the grade 1 or the mild malnutrition. 60 to 74% grade 2 or moderate malnutrition. Less than 60% is grade 3 or severe malnutrition. Then the third one is Waterloo classification of malnutrition. Uh, that focuses on weight for height and height for age. Weight for height will label wasting, and height for age is used for stunting. So if wasting is weight for height is more than 90%, it's normal. 80 to 90% is mild, 70 to 80 is moderate, and less than 70 is severe. Then stunting is labeled when height for age is more than, if it's more than 95%, the state is normal. 90 to 95% mild stunting, 85 to 90% moderate stunting, and less than 85% is severe stunting. Then we come to the fourth classification that actually is for protein energy malnutrition. That is Jalf's classification according to the weight for age. When the weight per age is more than 90%, it's normal. 80 to 90 is first degree of protein energy malnutrition. 70 to 80 is the second degree. 60 to 70 is the third degree, and less than 60 is the fourth degree of protein energy malnutrition. Now we come to the prevention of malnutrition. We will focus on the five levels. The first level is the primordial. The goal is to prevent risk factors, food security, poverty reduction, females education, regulate junk food. Primary prevention goals for prevention of the onset of disease. So breastfeeding promotion, fortification, immunization, and wash improvement can be done. Secondary prevention focuses on the early detection and growth monitoring, wax screening, and early moderately acute malnutrition should be managed early. Tertiary prevention goals for treatment and rehabilitation. So the inpatient and outpatient um, acute malnutrition should be done. Management should be done, and nutrition rehabilitation and follow-up should be there. Quaternary prevention goals for to avoid the harm for to avoid unnecessary hospitalization, rational treatment, and ethical care. So the over treatment and over investigations should be avoided in this stage. Now we come to the second portion of this presentation, that is assessment of nutritional status. The first method is anthropometric assessment. So the measurement of the body size and proportions. This includes weight, height or length, BMI, MOAC, that is mid upper arm circumference, and skin pore thickness. This is useful for assessing growth and body composition. Uh, then comes clinical assessment. That is based on physical signs and symptoms of deficiency or excess. For example, pallor will give hint about the anemia, bite or spot about vitamin A deficiency, and edema will tell about severe malnutrition. This is simple and inexpensive, but subjective. Biochemical assessment includes laboratory estimation of nutrients or metabolites. The examples are hemoglobin, serum ferritin, serum retinol, nucleic acid. This is most objective and detects subclinical efficiencies as well. Dietary assessment evaluation of food intake pattern. Common methods are 24-hour recall, dietary recall, food frequency questionnaires, and dietary history. This helps identify inadequate or imbalanced diets. Functional assessment include this measures the functional consequences of nutrient deficiencies. The examples are dark adaptation test for vitamin A deficiency, physical work capacity, immune response. This reflects the physiologic impact. Then the last method is the ecological or socioeconomic assessment. It studies environmental and social factors like income, food availability, cultural practices, and sanitation. This is useful for community level assessment. Now we come to the recent updates. The first article is about the advances in artificial intelligence and precision nutrition approaches to improve maternal and child health in low resource settings. So there is an article um, that AI-based models demonstrate high predictive accuracy in the malnutrition detection, and the AI-driven virtual dietitian systems improve the dietary adherence in like 84% and reduce the unplanned hospitalization. And the AI also demonstrates significant potential in the optimizing malnutrition screening, body composition monitoring, and personalized nutritional interventions for cancer patients as well. Then the third article is about the artificial intelligence in malnutrition. This is a systematic literature review that AI-driven solutions are already making significant impacts, such as using big data analytics for comprehensive food insecurity assessments, AI-powered nutritional interventions tailored to the needs of vulnerable populations, and AI-based early warning systems for predicting and mitigating food shortages. Then this article is small quantity lipid-based nutrient supplements for the prevention of child malnutrition and promotion of healthy development. The overview of individual participant data, meta-analysis, and pragmatic implications. Small quantity lipid-based nutrients. These supplements are designed to provide multiple micronutrients within a food base that also provides energy, proteins, and essential fatty acids targeted towards preventing malnutrition in the vulnerable populations. These are actually um, used to treat a severe acute malnutrition along with a route of fundus of treatments. So now we come to the practice of MCQs. The first question is a researcher wants to assess the nutritional status of a representative sample of children in village A, whether it is good or bad, is better or worse than that of the village B and C, and whether it is improving or deteriorating over time. The most appropriate means to carry out such an assessment in a community is first one is anthropometry. Then we have clinical examination, option C, functional statistics, D, growth monitoring, and option E, nutritional surveillance.
A.
Yes, option A can be used for the assessment in the community. Question number two is a 3-year-old child is a rural in a rural community has a height for age Z-score of minus 2.8. The child's weight for height is normal and there are no signs of acute malnutrition. What is the most likely diagnosis? Option A, wasting, B, stunting, C, underweight, D, marasmus, and E, obesity.
Stunting.
B.
Yes, B is the right answer. Question number three is a national policy introduces mandatory fortification of wheat flour with iron and folic acid to prevent anemia among women of reproductive age. This measure falls under which level of prevention of malnutrition? Option A primordial, B primary, C secondary, D tertiary, and E quaternary.
Primary.
A.
Option B is the right answer as we are targeting a special group of women. Uh, Question number four is a 2-year-old child with severe acute malnutrition is assessed at a community health center. His weight for height Z-score is minus 3.2 and MUAC is 10.8 centimeter. The child is alert, has no edema, and is able to eat. What is the most appropriate next step? Option A, admit to the hospital for nasogastric feeding. Option B, provide ready-to-use therapeutic food route of and manage as an outpatient. Option C, start immediate high protein feeding. Option D, give only nutrition therapy. And option D, IV therapy.
B.
B.
Yes, B is the right answer. Question number five is a 5-year-old girl is brought to the clinic with complaints of irritability, swollen legs, and a swollen belly. Her diet mainly consists of maize porridge. On examination, she has signs of edema, hepatomegaly, and a flaky paint dermatitis. What is the most likely diagnosis? Option number A, marasmus, B, rickets, C, pellagra, D, kwashiorkor, and E, beriberi.
What's
A.
your call?
Yes, kwashiorkor is the right answer because she has edema as well. Question number six, a young anxious mother visits the primary health care facility and expresses concern about the lack of age-appropriate growth of her infant who is currently at 6 months of age. And the most appropriate means to detect early onset growth faltering in this child would be option A, anthropometry, B, clinical examination, C, functional statistics, D, growth monitoring, and E, nutritional surveillance.
A.
Yes, option A
E.
is the right answer for the early onset detection. Question number seven is a community health worker is screening children for malnutrition using MOAC tape. A 15-month old child has a MOAC of 11.0 centimeter. What is the most appropriate classification of the child's nutritional status? Option A is it's normal nutrition. Option B, mild acute malnutrition. Option C, severe acute malnutrition. D, overweight, and E, stunted but well nourished. It's a severe acute malnutrition. Option C, as MOAC is of 11. All right, now we come to question number 8. A research team tests a small quantity lipid-based nutrient supplements among children ages 6 to 23 months in a food insecure area. They find a lower rate of relapse after discharge from CMAM, um, community management. Which statement best describes the role of these small quantity lipid-based nutrient supplements in the malnutrition supplements and prevention? Option A, used as treatment for severe acute malnutrition in hospitals. Option B, used as supplementary food for prevention of the undernutrition in high-risk populations. Option C, used only in tertiary care after full recovery. Option D, replaces ready-to-use therapeutic food. And option E, given to children more than 5 years only.
A.
B.
Uh, it's C. Option is C, used only in tertiary care for full recovery. Question number 9 is a 14-month-old child is brought to the clinic with severe weight loss, visible ribs, loss of subcutaneous fat, and muscle wasting. The child appears alert but irritable. His weight for height z-score is -4 standard deviation. What is the most likely diagnosis? Option A, kwashiorkor or marasmus, or rickets or vitamin E deficiency, or moderate acute malnutrition.
B.
Yes, now this is B, marasmus, because muscle wasting is there. Question number 10. A rural community has a high prevalence of child malnutrition due to poverty, unsafe water, and poor sanitation. A multi-sectoral program is launched focusing on improving food security, wash, and maternal education. This program represents which level of prevention? Option A, primordial, B, primary, C, secondary, D, tertiary, and E, quaternary.
B.
Option A is the right answer, primordial prevention. This is the answer key to all of the questions. This is the YouTube channel of Institute of Public Health where this presentation will be uploaded later on. Thank you.
Thank you so much, Dr. Aamna. It was a very good presentation.
Thank you so much.
Thank you so much, Dr. Amna.